Hello, welcome everyone. I'm Suresh Nair. I'm a medical oncologist and physician chief of the Lehigh Valley Topper Cancer Institute. This is amazing to look at and see the survivors, to see our medical oncology, radiation oncology, surgical oncology colleagues, our community philanthropy partners, and really we're here to celebrate survivorship. We just took the survivor picture, which just gave me chills. And we have a very exciting program for you tonight. Just to set as background, this is actually our first annual Pancreatic Cancer Symposium for Lehigh Valley Topper Cancer Institute. And this is something that's very exciting and dear and near to all of us. I'm a medical oncologist. I practiced in the community setting for 33 years. I'm almost year 20 at Lehigh Valley. This is a wonderful place to practice. And my own areas of expertise are immunotherapy. I specialize, I take care of all cancers, but specialize in melanoma, kidney cancer. And we've had very similar events to this for melanoma now going on 10 years, and kidney cancer going on about 7 years. And I do think as a result of tonight, the survivorship and quality of life is going to improve, because I've seen it absolutely happen when the community, the patients, the survivors, the medical professionals all come together. There's a certain passion that'll come out of tonight that will, just last all year, and it's gonna, you'll see a difference. And I so appreciate everything. The inspiration for tonight really came from Laura Beaupre. Laura's, has been a long-term nurse leader at Lehigh Valley. She was head of navigation, but she along with her friends started what was called Jace Run in Whitehall and Copley, phenomenal program, and then funded and then became Pancreatic Cancer Hope Foundation, and funded our translational freezer that we use for some of our trials, especially with Sloan Kettering. Lehigh Valley is fortunate to be picked to be one of their 3 alliance partners with Memorial Sloan Kettering. And we have Dr. Kevin Soros, who battled I-78 accidents to come from MSK and to really give us the most exciting thing, I think, that's happening in cancer research, specifically in pancreatic cancer research that's going on at MSK. And then we have Laura Ferran, from Fighting Ferran's Foundation. Lauren, in the last row we have, or the last table, some of my colleagues from Topper Cancer Institute that take care of pancreatic cancer patients. We have Dr. Usman Shah, who's chief of Hem-Onc, Dr. Magid Khalil, who's my associate chief of research. We're best of friends and we partners. We have my partner, Nick Lamprella. I saw Dr. Ali from our Pocono right here. And we have Dr. Aaron Blackham, who's one of our 2 pancreatico-biliary surgeons. Aaron is a phenomenal surgeon and colleague that also works with me in melanoma. Jeff Brodsky, his colleague, is also a phenomenal robotic, they're both robotic pancreatic surgeons, and both have a big research background. Dr. Nick Lamprella, one of my partners, who does specializes more in breast cancer and oncology, but all of us support each other in research. So, I want to introduce first Laura Beaupre. Laura is president of Pancreatic Cancer Hope Foundation, and I'd like her to kind of start the night off because this is her inspiration.
Thank you, Dr. Nair. Good evening. As Dr. Nair said, I am Laura Beaupre. Though I've been a nurse at Lehigh Valley longer than Dr. Nair's been there, many years longer, I'm here tonight in one of my other roles as president of Pancreatic Cancer Hope Foundation, or as we call it, PC Hope Foundation. On behalf of our board, who is here, Anitra Winkler, Tom Beaupre, Kelly Ramage, Debbie Schweitzer, and Ann Miller, who couldn't be here, I'd like to welcome you and say how happy we are to be co-sponsoring this event tonight. At PC Hope Foundation, our mission is twofold: to raise funding for pancreatic cancer awareness and research, and to support people going through treatment for this disease and their loved ones. Each of us on the board have been through this with loved ones of our own, and we have been working for years to fulfill this mission in the hopes of earlier detection, better treatments, and one day, a cure for pancreatic cancer at all stages. Our foundation started as a small nonprofit back in 2009 called Jay's Run. Jennifer Locanti, who's an honorary board member of PC Hope Foundation, she's not able to be here tonight, but she organized a 5K in honor of her mother, Joan Stein, who had lost her battle with pancreatic cancer just 5 months earlier. The 5K was called Jay's Run after Joan and another young local woman, 39 years old, Jennifer Reeves, lost her life to pancreatic cancer the day after the first 5K. Jay's Run 5K continues to this day, taking place the first Saturday in May each year at Sailor Park in Copley. Our next event is May 4th, 2024, if anybody wants to come out. It's a walk, run, it's family friendly, and I promise you, we will welcome you with open arms. Even if you just want to be a cheerleader, that's fine too. We love to have you. I promise you our community is welcoming, and we have more information on our website, our rack cards, and business cards that are on our table out front. In 2019, we made the decision to build upon Jay's Run success and create the Pancreatic Cancer Hope Foundation in order to grow our footprint in the community and create more opportunities like tonight's event. Jay's Run 5K, however, will always be our signature event and close to our hearts. Over the past 15 years, our group has worked tirelessly in the community to honor both important parts of our mission. We helped to fund a pancreatic cancer surveillance study at Lehigh Valley back in 2014. We helped to fund a phase 1 lab and pancreatic cancer tissue bank and genomic testing for pancreatic patients at Lehigh Valley back when it wasn't universally covered. Last year, we gave funding to St. Luke's Hospital for equipment for their clinical trials and research lab. And for the past 2 years, we've helped to fund original research at Johns Hopkins with Dr. Marcia Canto, using AI to improve early detection via endoscopic ultrasound. Her work is showing progress, and we're happy to be a part of it. The second part of our mission is to support people going through treatment for the disease and their caregivers and loved ones. Back in 2015, we reached out to our friends at Cancer Support Community to create and fund one of the few PC support groups in the Northeast, helping this very specific group of people with unique needs. Cancer Support Community, if you aren't familiar, is a wonderful nonprofit with a local chapter right here in the Lehigh Valley. If you're not familiar with them, please take a moment to say hi to them. They have a table out front, or go to their website. All of their programs are free of charge, and they help anyone affected by cancer. Our newest initiative this year involves what has been identified as one of the biggest needs for pancreatic patients at Lehigh Valley Hospital, assistance with oral nutrition supplements. We have given funds to the dietitians at the Topper Cancer Institute to increase their stock of Ensure on site to give to any patients who need them. And we hope to continue to supply Ensure through ongoing donations throughout the year. We have more information about our monthly donor initiative on our table this evening if you're interested. I'd like to thank Dr. Suresh Nair, Physician-in-Chief of Topper Cancer Institute, for his unending support of our foundation. I'd like to thank Dr. Brian Nestor for being here and supporting us. I'd like to thank Dr. Magid Khalil, our medical advisor at PC Hope and a medical oncologist at Lehigh Valley, and the team at Lehigh Valley for helping to organize the event this evening. I'd like to thank Dr. Soares from Memorial Sloan Kettering for coming this evening and discussing this very exciting new research. I'd like to thank the pancreatic cancer survivors who are here to show us strength and give us all hope. I am blown away by the number of survivors here, and we're so happy to meet you and see you. And lastly, I'd like to thank the members of the community who are here to learn, to share, to support each other, and to help us all raise critically needed awareness of this disease. Lastly, I'd like to close with a short video created last year for our foundation to show the community what we're about. Thank you and enjoy. I'm involved in Pancreatic Cancer Hope Foundation because I want to make a difference, because I feel passionately that this disease doesn't get enough awareness and that we need to find a cure and early surveillance.
To me, it's very personal. My father had passed away from pancreatic cancer almost 20 years ago. Each board member of our foundation has been personally affected by watching a family member or loved one battle pancreatic cancer.
I started my journey in 2011 when my father was diagnosed with pancreatic cancer. At that point, we knew nothing as a family, and I wanted to do something for others to help them hopefully get through it a little bit easier than I did. When my dad was diagnosed, I reached out to the community to find out who's been affected by it, what has helped them, and that's how I found Jay's Run.
I got involved in the Pancreatic Cancer Hope Foundation because of the impact that this terrible disease has had on my wife's family. And over the years, working with the foundation and the amazing board members, the mission that we have has just become even more and more real and important as I've gotten to know survivors, their families, other families who have also been impacted by this disease.
For me to be a board member is three things. One, it's action, it's hope, and it's strength and togetherness. I was asked to be a board member shortly after my mom was diagnosed with pancreatic cancer, and it was a very easy answer for me to say yes, because at that point I felt very helpless. I didn't know what I could do, but I knew that I had to do something.
I was diagnosed with my pancreatic cancer and lung cancer in February of 2020. So then in May of 2021, I was in my recovery mode from pancreatic cancer, so I could only walk a quarter of a mile. And I wanted to see how this is all done, and saw the excitement between the people that were there, and watched the walkers and different things as far as to what people did. And there again, it made it more real that they were doing this for me. Now this year, 2022, I'm on the side of survival.
We have people that come year after year to volunteer with us. We have people that donate money every year. We have sponsors that support us every year. And we have the participants, the runners who come every year and run for the people that can't. And they come in all sorts of weather, but in the cold and rain, they were running and they were keeping in mind the greater goal.
Pancreatic cancer is the #3 cancer cause of dying, and that's national, and that's in the Lehigh Valley. I'm a medical oncologist, and I lead clinical trials at the network with Memorial Sloan Kettering. Over the last 12 years, the patients in the Lehigh Valley have had this wonderful organization having their back.
The Pancreatic Cancer Hope Foundation has been a true friend to us at Cancer Support Community. Because of their funding, we were able to start a monthly support group for people affected by pancreatic cancer, as well as offer some individual counseling and some special events.
Because of reading and understanding the importance of early detection for pancreatic cancer, research is vital. And research can only happen by people donating. And when fundraisers are done like this, it gets many people involved.
We've been working with PC Hope and having germline genetic testing of pancreatic cancer patients so that they can benefit from medicines called PARP inhibitors in addition to chemotherapy. Now we're working with PC Hope in 3 very innovative clinical trials.
Every year when I look back at how far we've come the past year, both as a group, as a foundation, and research at large, I think to myself, I really think we'll get there. I do. There's hope.
The important thing is to believe in yourself. Believe that you can kick this thing in the butt. And I tell you what, put on your gloves and fight like the Dickens. Life is worth living.
Thank you so much, Laura. I know it's very emotional for all of us. All of us have some tears, and when I think of the Jay's Run, it's like a day of love, and Sailor Park is about the flattest park I've ever. There's no hills there, and it's one of the most scenic. So I really encourage you to spread the word about the event. We have a surprise guest here that has had a big effect on the cancer program, on my career here, and on us being a cancer institute. Dr. Brian Nestor, who's president and CEO of Lehigh Valley Health Network, who's had cancer brushes in especially his wife's family, and has been a tireless supporter of cancer research. He comes to all of our events, I just wanted to introduce Brian to say a few words, especially since we have Dr. Kevin Soros, who's part of an elite research group, and just to show that we are very serious about partnering. We're already partnering with MSK, but we're launching something very special called the Personalized Cancer Immunotherapy Program, something that I'll be leading with my colleagues that are in the back. We've gotten a very generous philanthropy from another family, a family that I take care of for ovarian cancer. And we're really in a golden age where, with genomic medicine, with understanding the immune system, things that we've been so powerless to handle, all of us, I've been at it for 33 years, Dr. Khalil, Dr. Shaw, a long time. Things are within our grasp, and so, but having institutional support and vision to make us the Cancer Institute, and then the Topper family endowing us and giving us steady research support, really being able to continue with programs through the ups and downs of healthcare. So, Brian, if you can just say a few words, and welcome Dr. Kevin Soros.
Thanks, Suresh. What a wonderful impromptu opportunity. I'm here for probably 3 reasons. The first of which is a lot of wonderful things happen in our network every single day. I try to go to as many of those wonderful events as I can, but I would tell you nothing is more inspiring than being at a cancer survivor event. Nothing I attend, nothing. You can feel down, you can feel bad, and you go meet the most inspiring people you have ever met. And whether they are actual survivors or family members of those who cared for loved ones that they lost, they're all inspiring. And I love coming. And when I heard about the event, there was no way I was going to miss this. So congrats to everyone who pulled it off and brought it together. It's a blessing to be here. The second reason is that cancer has hit my family, mostly my wife's side, with loss of my mother-in-law to pancreatic cancer, father-in-law to another gastrointestinal cancer, and many others, honestly. But this is a time to celebrate because we are in a medical renaissance, largely in cancer care. In my career, the 2 things I will be most grateful for in 40 years of medicine is number 1, LVHN's commitment to the mentally ill and behavioral health. That is a long-standing commitment that we've had even before I got here. The other is our investment in cancer care. We are going to watch, at least in my lifetime, an opportunity to survive cancers that even 15 years ago, my in-laws would still be alive today because of that. So I'm here. When I heard we had Dr. Shores coming, talk about the vaccine and the exciting news. There's no way I was missing that. So thank you for taking the trip down. Not an easy trip. And we appreciate you being here. We are 1,000% in on traveling with this science and contributing in every way possible on clinical trials, doing our own research, being an assist to these fabulous innovations that are coming out of Memorial Sloan Kettering literally every month. So it's a great time to be in this space. And as a provider, I think if you're a patient or a family member of a patient dealing with cancer, there is good news around the corner, and you can actually feel like that's the case. The third reason I'm here is I'm on a perpetual competition to prove that I am Suresh Nair's #1 fan in America. So in case anyone wants to come up and talk about it as well, I welcome you, but I'm going to win. All right. No, seriously, I talk about Dr. Nair in a very loving way because he's been a provider for us, doctor for our families. But I watch him with many other patients. I've probably referred 100 patients to Dr. Nair. Every one of them is a boomerang that comes back and says, "Thank you for getting me into that doctor," and with his colleagues, because he can't see everybody. He has a fabulous group of colleagues here that. If I need cancer care, there's nowhere else I'm going. It's this group right back here and with Dr. Nair. And then my last comment on him, and the crazy thing is, he is one of the top 5 doctors I've ever met in my entire career, but he's even better human being. That's what makes great doctors. Thank you, Suresh, and thanks for having me here, Dr. Soros.
Dr. Soros obtained his undergraduate degree at Brandeis University and his MD from University of Massachusetts. He did his general surgery residency at Johns Hopkins, and there's a legendary pancreatic cancer surgeon, Dr. Cameron, at Hopkins. He actually won the Dr. Cameron Award during his residency, which is quite a prestigious thing. He also worked at Dr. Jaffe's laboratory at the Sidney Kimmel Cancer Center at Johns Hopkins. And Kevin, Liz Jaffe and I were at University of Pittsburgh together way, way back. This is in the 1980s. She was did a year post-residency before her fellowship at Hopkins, and I was a first-year fellow, so she was brilliant even back then. And then after finishing residency, he completed a 2-year dual fellowship in complex surgical oncology and hepatopancreatic biliary surgery at Memorial Sloan Kettering. He was appointed to the faculty of Memorial Sloan Kettering. His primary research interest is combinatorial immunotherapy approaches in hepatobiliary malignancies. He has over 35 publications, probably more than that. This is an older, in peer-reviewed journals, authored 6 book chapters. And they're 2 surgical leaders of the pancreatic cancer vaccine program at MSK, Dr. Vinod Balachandran and Dr. Kevin Soros. So we're very proud to have host Dr. Soros to update us. Thank you.
Well, thank you, Dr. Nair, for that kind introduction. It's truly an honor, and Dr. Nestor, I appreciate the opportunity here as well. As you mentioned, these are the opportunities for us as providers that really make our job worthwhile. Being here with the community, seeing the resilience in the community, and seeing how we can work together and help make things better. For a lot of you, it's for the next patients, and your generosity and everything you're doing to help us do that is incredible. And this is also an opportunity that we can continue to foster these relationships with Lehigh Valley, which through the Topper Cancer Institute, through the Hope Foundation, it's really how we're going to make strides in the research we're trying to do and trying to make some improvements in this devastating disease. So we're going to talk today a little bit about where we stand with the disease today, which many of you know all too well, and then what we're trying to do and how we're trying to approach it to make some improvements, which are a little bit different than what's classically been done. So I have no disclosures. When it comes to pancreas cancer, if you look at the studies, one of the things you'll see over time, this is a registry review from the Dutch pancreatic cancer population. They do a tremendous job of collecting population-based data so we can see what's changed over time. And when you look at this, you'll see that there is an improvement of overall survival, 3.1 months in the late 90s, now it's 3.8, so that's statistically significant. But what does that really mean? That's a few weeks of improvement in survival over this entire 16, 20-year period. It's really very, very slow, small improvement. And this is the part of the curve which I think we all need to focus on, is where does it end? As we look at these curves, and there'll be some curves like this in the talk, as they get closer to 0, that means fewer and fewer patients are surviving a long time. You want that curve, the tail of the curve, to be elevated. And we have not seen that in this disease. And it's multifactorial why we have that problem in this disease. The reality is most patients with pancreas cancer present with very advanced disease. They never come to my office because they're not surgical candidates, up to 80% of patients. So only 20% of patients really present with a chance at a long-term cure. But these are the patients where we really have an opportunity for this long-term cure, where really we can make some strides in survival and understand how to treat the disease better for the entire patient population of pancreas cancer. The reality is, even with these patients who have a chance at a cure, the majority will recur. And when this disease recurs, unfortunately, we cannot cure it. So this is a really highly motivated subset of patients that really we need to focus on as providers, as patients, as a Hope Foundation, to try and make some strides in this disease, see what we can learn and improve the overall outcome here. The lessons learned here will be critical for the rest of the population. And when you look at studies starting to really focus on these patients, this is one such study, which is essentially a randomized controlled trial, international trial, randomizing patients with pancreas cancer who could go to surgery and get their surgery first, and then they either get multi-agent chemotherapy called FOLFIRINOX, which is the most utilized systemic regimen in this cancer, versus gemcitabine. And when we do this, we see that for the first time we actually see some what looks like encouraging data. Now, granted, very highly selected patients that were predicted to do a bit better given that we could remove their tumor. But the overall survival in this patient population that got the FOLFIRINOX in surgery was 54 months on average, which had never been seen before in this disease. So this is encouraging. The reality, though, is when you look at these curves, we still have issues, and that many of these patients we do not see getting to the point where they can survive a long, long time and ultimately be cured. So immunotherapy has obviously been very exciting. Immunotherapy has been a breakthrough for many cancers. It has not been such the case with pancreas cancer. And essentially what we're trying to do with immunotherapy is to tell our bodies, look, this is a cancer. Fight it like an infection. You need to beat this down. You use your immune system to do that. But the cancer has very intelligent ways of turning this off. And pancreas cancer especially has a very effective, many effective means of doing this. It's a very resistant it's a very resistant cancer to really any treatment. Chemotherapy, radiation, because of that reason, the fact that it comes back the vast majority of the time. But from an immunotherapy standpoint, it's considered a non-immunogenic tumor. If you look at a pancreas cancer, there are very few immune cells in that cancer, save for a very select few of patients, which have a mismatch repair deficient type of tumor. And their expression for the targets that we use for immunotherapy that's been so successful in other cancers like renal cell cancer and melanoma, such as PD-L1, which is an agent to try and stop the immune system from being turned off, that expression is very low. It's not useful in this cancer. They've tried those agents in this cancer by themselves and not seen any real effectiveness. So clearly we need a different strategy if we're ever going to have immunotherapy be a part of this disease. And so to do that, we really have to understand why is immunotherapy not effective, getting down to the basics of immunotherapy. And I won't bore you with the mechanisms here, but really there are three main strategies that pancreas cancer can do to try and keep the immune system from attacking it. One is to evade it altogether, meaning don't let the immune system even know that it's there. Two, they can suppress that attack from the immune system once it's there. It starts bringing in other agents that can turn off the immune system, other cells that can turn off the immune system, or start using the PD-L1, which it wasn't using before. But the other thing about pancreas cancer, particularly where the tumor starts, is this is a very dense network within the tumor itself. It's very exclusive. The reality is, as this pertains to what it does with immunotherapy and pancreas cancer, remains to be determined. But the fact of the matter is, it is hard for these T cells and immune cells to get there. And so what we've done classically when we're trying to look at new agents in pancreas cancer and many other cancers is use these immunotherapies where the disease has already been very progressive, meaning it's gone past and progressed through multiple lines of chemotherapy. People's immune systems are no longer as intact as they were when they first started, given all the chemotherapy toxicity that they've developed. And this is where we try to use immunotherapies to see if these agents have any effectiveness. So this higher tumor burden, this immunosuppression is not the ideal place for immunotherapy. The tumor microenvironment, when we're dealing with a tumor in the pancreas, is entirely different once this cancer gets out to anywhere else, such as the liver or the lungs. And so we can't really understand how these drugs work with a localized pancreas cancer in this scenario. And very importantly, if you test this in a metastatic setting, understanding why the treatment is working or failing becomes very difficult. You have very few biopsies, you can't see why the cancer is progressing, and we'll get into some of this, but the reality is immunotherapy is exploding. I'm focusing on vaccines, but there are a number of different agents that in reality we have to understand how to combine them to get the effect of this. And studies like the ones we've been doing over time really are limited in our ability to understand that. So in the time in residency, especially in Dr. Jaffe's lab, I got very interested in understanding how we can induce an anti-tumor immune response in pancreas cancer specifically, given the difficulties that we had had up until that point. And Liz Jaffe and her group had really pioneered using one of the first pancreatic cancer vaccines called GVAX, which is GM-CSF secreting vaccine. What that means is essentially tumor cells from prior patients were taken, irradiated, and engineered to secrete this agent called GM-CSF. And when you give this vaccine to patients, it allows for what we hope to have the tumors in the setting of an area where you're developing an immune response and teaching your immune system to attack these tumors wherever they might be and activate what we think are the most effective means of treating a cancer with your immune system, which are tumor-specific T cells that are programmed to go and kill the tumor. And so very early on when they were using this, they decided to do a study that rather than focus on the metastatic setting, they focused on using patients who could go to surgery. And they get their dose of vaccine before surgery, 2 weeks before surgery. Move forward with surgery and then another dose of vaccine once they've recovered, followed by the standard of care chemotherapy, and then ultimately 4 more vaccines. This study had multiple different agents, so you can start to see the need to start to combine things very early on. This was done many years ago, but using cyclophosphamide to try and attack another part of the immune system and better understand the better way to do that. But ultimately, when I was coming into the lab, this is what we saw, is that patients who were going to their surgery and then having their tumor resected after vaccine for the first time had organized lymphoid structures called tertiary lymphoid aggregates within the tumors of pancreatic cancer patients. And the staining and you see here, the brown, the CD3 and the CD20 are the T cells and the B cells in an organized fashion. This looks very much like what a lymph node will look like, but now it's within the pancreas tumor itself. And this was vaccine dependent, meaning if you weren't vaccinated, they looked at a number of patients who had never been vaccinated that they had there, you did not see these lymphoid aggregates within the tumor. The vast majority of patients, 33 out of the 39 vaccinated, did. And so this was really of interest because now we're starting to see, okay, well, something's happening here at the tumor microenvironment level, but we really got to understand what it is and what it means. Is it effective, or is it just the beginning of a process that needs to be further altered to really improve on the effectiveness of the vaccine? And so that's where the subsequent studies started focusing on the types of immune cells that could turn off this immune response. And that included regulatory T cells, which are a known subset of T cells which, instead of helping the cause, turn off the immune system. But also, and very importantly, we started to see that PD-L1, PD-1, which has been used in many different cancers, well, unvaccinated patients don't have it, as evidenced here by the top one. But when you vaccinate patients with GVAX, a lot of these lymphoid aggregates, and within the tumor itself, this brown staining here is indicative of that this is the tumor's cry for help. To try and turn off the immune system is one way to look at it, and try to use other agents to turn off these T cells. And even within these lymphoid aggregates themselves, we could see that the PD-1 and PD-L1 is there. So this suggested that perhaps by understanding what's happening at the tumor level, we're starting to see what the tumor is trying to do to turn off this immune system and can limit its effectiveness. And during this time, or toward the end of this, my partner, Vinod Balachandran, who I work closely together in his lab, asked a very simple question. You know, we looked at those curves. Some patients, though, they live a long time. And we really don't understand why some patients that may have positive lymph nodes, positive margins, somehow they live a long time, and other patients don't. Most patients don't. But there's really no difference in the way they were treated, and we didn't know what the reason. So he wanted to know why. Why do we have patients who live such a long time despite getting the same treatment? So he first looked at patients from Sloan Kettering and separated them out. Took a group of patients who had lived on average a very long time for this disease, on average 6 years, and compared them here to patients who really passed away in the normal expected amount of time, unfortunately very quickly. And when he looked at what was going on at the tumors, and he also had peripheral blood samples, he could see that these patients that were living a lot longer seemed to have a lot more T cells, CD8 T cells within their tumors, about a 10 to 12-fold increase in T cells within their tumor. Interesting observation, but also something that had been noted and seen in other cancers, where increased T cell infiltration seems to correlate with a better outcome. And the reason is why. I mean, this is, up until this point especially, been thought to be a non-immunogenic cancer. How can T cells be playing a part in anything that has to do with long-term survival if it's considered a cold tumor? But when he looked at what's going on within these tumors themselves, he did identify what's called neoantigens, targets, that the immune system could then target with their vaccine response, or in this case, just an inherent induced anti-tumor immune response. Neoantigens are essentially the way your cancer develops. There's through mutations, and these mutations are what's foreign. They shouldn't be there, and this is what your immune system can understand and attack. And in pancreas cancer, it was always thought there weren't really many neoantigens, but in reality there were, on average, about 38 neoantigens. And when you really looked more closely at these neoantigens, what we could see is that if you look at and try to decipher what are high-quality neoantigens versus low-quality neoantigens, not the quantity, meaning how many, but really how effective these could be at generating an anti-immune response, those patients who had high-quality neoantigens through his predictive pipeline lived longer than those who did not. So the quality of the neoantigens seemed to predict their outcome, which was of interest. So the next natural progression as it pertained to this was that, well then, if this can happen inherently, and these patients can live a long time, they're very few and far between, what can we do to stimulate this process in patients that we're treating so that we don't have to rely on the immune system doing it on its own? And that's where the thought of mRNA vaccination, way before COVID became the reason why we all understand mRNA vaccination today. But that's where the thought was, okay, well, if we can identify these neoantigens, let's do a study where we have a vaccine that we can readily make, depending on everybody's tumor, specific to their tumor, but really transferable, meaning adaptable type of vaccination. That's where mRNA vaccine became the appropriate target for this first study. So this is a study that, when you think about it, really starts its conception in 2017, but its first patient was enrolled in December of 2019. And these were patients who had resectable pancreas cancer, no evidence of spread, never been treated. And they would go on to get their standard of care surgery, all done at Sloan Kettering, followed by getting their tumor immediately sent away to the company which collaborated on this, which was BioNTech over in Germany. They processed the tumor we processed the tumor right away, sent it to them, and then they process it and ultimately identify the neoantigens in each of these tumors and stimulate and create a vaccine that's specific to that tumor, that's going to target those neoantigens. And so while that's ongoing, the company is making it, patients are recovering, and we're giving them 1 dose of the atezolizumab, which is the PD-L1 inhibitor. And then on week 9 after surgery, they get their priming doses of vaccine. In this study, it was doses 1 through 8. And once they complete that, they go on to get the standard of care chemotherapy they would get anyway, which is the FOLFIRINOX, and ultimately 1 booster dose afterwards. And so this trial was designed to really look at 3 things. 1, is it safe? It's a phase 1 trial. We just want to make sure that we can give the vaccine and that patients can tolerate it. 2, is it feasible? Can this be done? Can we get the tumor out? Can we process the tumor right away, get it across Atlantic, get it back, and give it to patients start therapy within 6 weeks of surgery, which after these types of surgeries was definitely a question that needed to be looked at. And 3, we wanted to see, well, does it do anything in the way, meaning does it generate any anti-tumor induced response that we can identify? So as you might imagine, starting December 2019 with the first patient created some issues because 2020 was, of course, busy. So, clearly with the global transport chain being affected, with hospitals stopping, we like many others, and I know here was affected significantly as well, limiting our clinical activities to a point. It was a challenging time, but ultimately actually we're able to continue with the trial through that time, which really speaks to the dedication of the study team and the company that was working with us, who was also busy doing their own thing with COVID vaccines. And ultimately able to accrue the trial and complete the trial within 1 year ahead of schedule, where ultimately 16 patients were vaccinated. And from the safety standpoint, it was safe, meaning that patients tolerated this well, very few adverse effects, and we were able to get everyone to therapy within more or less 3 days of the targeted treatment day, which is week 6 after the surgery. So from the question of safety and feasibility, both appeared reasonable. But then we started looking at, well, is this doing anything? And we looked in the peripheral blood of these patients to see, do they have any response to these antigens that we've included in the vaccine? And we saw that 50% of the patients, so 8 out of the 16 patients that got vaccinated, were responders. The other 8 were not. And when you look at the responses, which is here in the top left here, you can see that in some of these patients, up to 10% of all their T cells were tumor-specific T cells. And this resulted in a long duration, meaning they could persist even through FOLFIRINOX, which is a very intense and, as you know, a tough chemotherapy. Even up to 2.5% of their T cells persisted as vaccine-specific tumor cells that through the chemotherapy. And some of these patients responded to one neoantigen, half of them responded to a couple, but the reality, it didn't seem to matter. But what we also saw, which was an interesting signal, and in a limited study like this, that's the extent of what you can say to this, but the reality, it seemed to be that if you were a responder, it seemed to correlate with a less likelihood of having your cancer come back. So those that responded, when you see here, are in the red, and each time there's a recurrence, you'll see it come down. So those responders here in red, at the time of this publication, had not had a recurrence. Those that were non-responders are here in blue, and appear to be responding more or less when you would expect things to happen as you treat cancer, this type of cancer, on a regular basis. So this is certainly an interesting signal. And now we are really asking the question is it really effective? And this is a study that's ongoing now. This is now going to be a global study. We've opened it at Sloan Kettering, and there are other trials or other facilities that are going to be opening across the world, approximately 80 sites total, and planning to enroll approximately 260 patients total. And in some ways, it's a very simple study. You get randomized to the standard of care in one arm. These are, again, patients who could have upfront surgery, no prior therapy. And you either, when you have randomization after your surgery, you either go to the chemotherapy arm as you otherwise would, or you're in our intervention arm, which is the combination of the vaccine and the PD-L1 inhibitor. In this situation, what's different from the phase 1 is that the chemotherapy is now starting earlier. The immunotherapy is starting a bit earlier to decrease the delay to the chemotherapy that was in the phase 1. And we're doing more boost doses after the chemotherapy is complete. So, more to see, more to know as we go through these trials and really understand what the effectiveness of this is and really understand why some respond and some don't, particularly if this continues to be effective. But what's also encouraging is that this isn't happening in a silo. As you look at immunotherapy for pancreas cancer, there are other approaches that are being utilized, some of which at our institution as well, looking at KRAS vaccine. So KRAS is a protein that's mutated in nearly 90% of cancers, thought to be one of the initial aspects of what creates pancreas cancer. And this vaccine is created now to target that mutation. In this particular version of the vaccine, it's targeting 2 of the KRAS mutations. And this is, again, a trial that was utilized in the patients who had had complete resection of their tumor, but at a higher likelihood of their cancer coming back because either their tumor marker was still really high, or they had circulating tumor DNA that was noticeable. So these patients, when you look at their scans, you don't see cancer, but they're certainly at high risk, as all patients with pancreatic cancer are, for having their cancer come back. And this is the first study with that first version of the vaccine. And you can see that the blue down the colors here are just the increasing doses of the vaccine because they're trying to find the right dose. But as you get toward the end here at the higher doses, you can see that as these bars come down, this is indicating that in all these patients, they have a nearly 100% clearance of either their tumor marker normalizing or having their ctDNA disappear. And very similar to what we see with the vaccine, the neoadjuvant vaccine trial, is that if you have a response, in this case, they dichotomized responses, those that were above the median T cell response and those that were below. And those that, again, had above the median response, meaning their T cells were seemingly active against the cancer, again correlated with a much lower likelihood of having their cancer come back, which was statistically significant. So I find this interesting a lot, mainly because they sort of support each other. And the way we're doing this, what we're seeing, these vaccine responses seemingly correlating with survival differences, but these data are way too early, and now we need to do the trials, and this is where the collaborations come in. We're going to start, these trials are just going to get bigger and bigger, and once we have a signal like this, it really takes working with the community and the Lehigh Valley Network included so that we can all work together and get these trials done and really get the answers to these questions and not take, careers to answer one question with one trial. We have to expedite these things, and this is the way we can do it by collaborating like this. So we're now also looking at how we can try to do this to a larger, broader patient population in this disease. Like I said, 20% are resectable, but the reality is a large portion of those are actually still getting chemotherapy first and wouldn't be eligible for these paradigms. So one of the trials we're designing now is to try and combine these vaccines with the chemotherapy in patients who are going to surgery. Because chemotherapy will remain the backbone. It will remain a consistent part of the treatment. And so moving forward, if these agents have some promise, we have to understand how to incorporate the two. So we're looking to do this trial moving forward where we can start to combine vaccine, this KRAS vaccine, with PD-1 inhibitor in patients who have a very good chance of going to surgery, meaning they need chemotherapy, but there's no evidence of spread and the tumor is removable. So, in conclusion, novel agents obviously are really needed. We haven't made enough progress in this disease. And what we are seeing with these small studies thus far is that when we see vaccine-induced responses, they seem to correlate to better outcomes, and we need the real answer as to whether or not this is true. And so these designs that we're working with and doing these trials in these patient populations really are key. And being here and being a part of this is a wonderful opportunity for us to prolong these established agreements and work together and really make a difference in this disease. So thank you very much for the opportunity to be here, and happy to take any questions.
As we all, have been hearing about, nutrition's really vital, as Dr. Shaw mentioned, for all of cancer, pancreatic cancer. Nutrition's also very important for the immune system. We're blessed to have Deanna from our program to give us some information about nutrition.
Hello, everybody. My name is Deanna. I've been with the Cancer Center for about 1.5 years now, so I work very closely with all of our physicians here, mostly at the Cedar Crest campus, but we have dietitians all across the network throughout all of our cancer centers. So in Hazleton, Pocono, Muhlenberg, you can find us just about everywhere. So today we're going to be talking a little bit about pancreatic cancer prevention. A lot of the recommendations for prevention can also be used for survivorship as well. So we're going to discuss a little bit about that. So here you can see how nutrition plays an important role in all the stages of cancer. So whether it's prevention, treatment, symptom management, or survivorship. So if we can use nutrition to prevent cancer as much as we possibly can, but sometimes we might just be diagnosed with cancer, despite our efforts. So then we can work closely with you during your treatment to help symptom treatment management as well. Then we also work very closely with nutrition and our patients into the survivorship role. So today we're going to mostly talk about prevention and survivorship because they do coincide diet-wise. So here you can see it is estimated that about 40% of cancer cases can be prevented through diet and lifestyle habit changes. So that's going to be exercising, alcohol consumption, smoking, and obviously your diet. So according to the American Institute of Cancer Research, body fatness or increased body fat is going to be the biggest risk factor for pancreatic cancer. So keep in mind that being overweight or obese is not just a risk factor for pancreatic cancer. It's also a risk factor for all different types of cancer. So that can be your colorectal cancer, your esophageal cancer, kidney cancer. All of those can be attributed to an increase in body fatness. So here you can see a map of the United States. So this is correlated from the CDC. So you could see that the prevalence of obesity in the United States is pretty high. Obesity is defined as a BMI of 30 kilograms per meter squared, greater than 30 kilograms per meter squared. So I know when you go to the doctor, you get your height and your weight done, and they kind of tell you whether you're overweight or you're obese. That's the number they're using, they call that BMI. I mean, you can see here in the state of Pennsylvania, we're looking at about 30% to 35% of the adults in our state are considered obese. And then recent studies have found that greater than 40% of the U.S. adults are overweight or obese in the United States. Insulin resistance, excess body fat can cause insulin resistance. This is when your muscles, fat, and liver do not respond to insulin like it should, and it cannot be easily taken up take up glucose from your body. When this happens, your pancreas makes more insulin to hopefully be able to keep up with some of this glucose. But when the pancreas cannot make enough insulin to keep up with the blood sugar levels, this is what leads to diabetes and increased inflammation. Excess body fat can also cause chronic inflammation. So chronic inflammation can be caused by many factors, including your obesity, also diabetes and heart disease, alcohol, tobacco use, all of that can cause inflammation. Prolonged inflammation can lead to oxidative stress, which we'll kind of get a little bit into that a little later in the presentation. But this oxidative stress can lead to DNA damage and cancerous cell growth. And then the longer inflammation is present, the higher the risk of cancer. Excess body fat can also increase hormone levels, and excess fat increases the production of certain hormones such as estrogen, which has been linked to an increased cancer risk. So what can we do to maintain a healthy weight? And that's going to be what we get into right now. So obviously diet is going to be one of the big factors to be able to maintain a healthy weight. So we want to avoid consuming a diet that is high in calories, high in fat, and high in added sugars. So our added sugars are going to come from more of the foods like our pastries, our cakes, our cookies, things like that. A lot of people do try to limit their carbohydrate intake because they believe that it's sugar, but some foods that are high in carbs, like fruits, our whole grains, are going to be very healthy for you, and we'll get more into that as well. We also want to limit our intake of red and processed meats. So those red meats are going to be your beef, your pork, your lamb, even some game meats like venison. I know a lot of people have been eating venison because it's lean, but it does still count as one of those red meats. Processed meats, those are going to include your bacon, your sausage, your lunch meats, things that are very salty and very highly processed. We want to try to limit that as much as possible in our diet, if not avoid it overall completely. And then we also want to increase our intakes of plant-based foods. So that's going to be our fruits, our vegetables, our whole grains, even our nuts and legumes. So our beans and lentils are all types of foods we want to include in our diet. Yes, some of these do have carbohydrates in it, but carbs are your friend. We want to have carbs in our diet. So increasing our intakes of these plant-based foods will also provide us with some health beneficial fiber. So dietary fiber has been shown to have an inverse correlation to cancer risk. So that means the more fiber you eat, the lower your risk of cancer. There are two types of fiber out there. So there's our soluble and our insoluble fiber. Soluble fiber is a type of fiber that dissolves easily in water. So you put it in your water, you mix it up, it's kind of like your Metamucil. You can find that in stores. That's going to form into a gel-like substance, and those types of fibers can be found in oats, applesauce, bananas, and also it can help with diarrhea as well. So if you're having any GI-related issues, that's a great trick to have in your back pocket. Insoluble fiber is one of those types of fibers that promotes movement of material through your GI tract. So it's things that don't really break down as much, but still great for your GI health. So that's going to be found in your vegetables, your whole wheat products, so like your whole wheat breads and pastas, and also your brown rice. Fiber obviously has many benefits. Both types of fiber, soluble and insoluble, can help decrease your risk of chronic diseases such as cardiovascular disease and diabetes by lowering your cholesterol and controlling your blood sugars. Fiber can also help maintain bowel health, so like we talked about, helping diarrhea, constipation, but also it can help prevent diverticuli, so we don't get that diverticulitis or that little infections in our GI tract, and also prevent hemorrhoids. And then it also can help with aid with maintaining a healthy weight. So by achieving a healthy weight, it can help you early satiety, make you full a little bit longer, so you maybe don't eat as much and eat as much as those empty calories. So those cookies, cakes, chips, things like that. That fiber keeps you full, keeps you healthy. And then how much fiber do we need in a day? We're talking about getting all this fiber in. It is recommended that you get at least 25 grams of fiber a day. Obviously, more is great. That's the low end of the recommendation. So more is better. Obviously, as we're trying to add a little bit more fiber into our diet, we do want to be cautious because a lot of extra fiber, and we're not used to the fiber, could cause a little GI upset. So a slow introduction of fiber into our diet if we're not used to it. And then some tips on how to increase our fiber intake. So you want to you can choose a high fiber breakfast cereal. So some of us might eat things like Rice Krispies. Those are a little bit lower on that fiber end. You want to try to find a cereal that's high fiber. So we're looking for about 5 grams of fiber per serving. So that would be like your bran flakes, your whole wheat Cheerios, and anything with fiber in the name is going to give you that good source of fiber. You want to make at least half of your grains whole. So that means maybe swapping out your pastas, your white pastas, for some whole wheat pastas, white rice for whole wheat rice. That'll make sure that we maybe get those extra fiber in our diet. If you are new to whole wheat products and you don't typically like the texture, because sometimes it is a little bit of a different texture than our white products, I always recommend trying to mix maybe half of our rice with white rice and brown rice to introduce that whole wheat pasta or whole wheat rice. So then you get a little bit of the whole wheat benefits, but also, kind of help it enjoy it a little bit more. But then work your way to eating more of the brown rice. So we want to also reach for some high fiber snacks. So you could switch out your snacks that are maybe chips, cookies, pretzels, for things such as nuts, fruit, whole grain crackers such as Triscuits. Even popcorn is a great whole grain snack. We just want to find one that's maybe not doused in butter and salt. Some air pop popcorn is definitely recommended. And then up your bean game. Anything that you can think to put beans on. So whether that be your salad, put it in a soup, or you can put it in your chili. Try to get those beans wherever you can. They're a great source of fiber, and they all have a lot of other benefits as well. And swapping your spreads out, so like your mayos, you can always use in place maybe hummus, guacamole, even just some avocado if you don't like those extra spices in the guacamole. Put that on a sandwich instead. Before you know it, you're getting a lot of fiber in your sandwich. You can top off your cereals with yogurt, or your yogurt or cereal with fruit and nuts. So if you have maybe, you can make like a little parfait of some kind. And then you also want to aim for at least 5 servings of fruits and vegetables per day. That'll make sure you really get your fiber intake. So to reiterate, we're looking at 25 grams of fiber a day. So what does a day look like? You can sit here and think, oh, 25 grams of fiber, that's a lot. Well, if you look out here, it's really not a lot of different foods, or it doesn't take a lot to add up to the 25 grams. If not, you see at the bottom there, 31 grams. So if you for breakfast have a fourth of a cup of old-fashioned oatmeal, so that's going to be your rolled oats, not your quick oats. Those are a little bit lower in fiber. And put in some berries with that and some nuts. That right there is a good high fiber breakfast. Lunch, you can have 2 slices of whole wheat bread with a sandwich and maybe an apple to pair with that, getting 9 grams of fiber right there. And if you add any vegetables on your sandwich, you're upping that fiber even more. Dinner, if you find a way to get some black beans in your dinner and then put some broccoli alongside with it, you're easily going to get 12 grams of fiber right there. And as you can see, 31 grams of fiber just in a simple day like that. So it's really not that hard to get that fiber, and we just got to know where to get that fiber from. So we're talking about all this fiber. What else do these plant-based foods give us? They also give us some phytonutrients. So phytonutrients are actually great natural chemicals that are produced by our foods. Our foods, so our fruits, our vegetables, our whole grains, use these phytonutrients to defend against UV rays, disease, and other environmental threats to help them thrive. And more than 10,000 phytonutrients have been identified in plant-based foods. So there's a lot out there. I'm only going to talk about a little bit of them. But they are also responsible for the color, flavor, and odor of our plant foods. So that beautiful bright color that you see of all of our fruits and vegetables, you can thank the phytonutrients for that. In addition to providing benefits to themselves, they also provide benefits to us. So they act as an antioxidant and anti-inflammatory for us, which is great. So some phytonutrients are considered antioxidants, but what's all the hype about this? So they can counteract unstable reactive oxygen species, or also known as ROS. And these ROS can be caused by smoking, alcohol, UV lights, and obesity. Reactive oxygen species are also known as free radicals. Free radicals are these unstable and lack electrons, so they scavenge the body to find additional electrons, and they steal these from other areas of our body, which can lead to DNA damage, protein damage, and lipid damage. So it's damaging a lot of parts of our body. The antioxidants help protect ourselves from these free radicals by donating their own electrons. And this helps neutralize them and prevents them from becoming carcinogens. When there are not enough antioxidants, so we're not getting our good fruit and vegetable sources in, or our whole grain sources, the body can't perform this electron donation. And then this can lead to that oxidative stress that I talked about a little bit earlier. This damage that's created by oxidative stress over time can lead to your many chronic diseases, such as your diabetes, your cardiovascular disease, and also promote cancer growth. When our body does have enough antioxidants, so we're getting in our fruits and vegetables, we're eating all of our whole grains, it helps ward off these free radicals. And they can help by regulating your hormones, stimulating your immune system, reducing inflammation, preventing DNA damage, and help with DNA repair. Also reduces cell damage and slows cancer growth. So we're talking about getting all these fruits, vegetables in, phytonutrients, antioxidants, all this stuff, but what's the best way to do it? Eating the rainbow. So like I talked about, all those fruits and vegetables are all beautiful colors because of the phytonutrients, really making sure that you're getting all different areas of this beautiful rainbow here, fruits and vegetables in our diet. So your red is going to be that lycopene, so you can find that in your tomatoes, your peppers, any of those red fruits and vegetables. That's going to be an antioxidant that helps protect against free radical damage. and it can be preventive against heart disease as well. Orange and yellow is going to be your beta carotene, so you can find that in your carrots, you can find that in your orange peppers, your oranges, and this also is a great antioxidant, helps support your immune system, and also helps support eye and skin health, so it's kind of like a double whammy. Lutein is going to be in your green fruits and vegetables, so your spinach, your broccoli, your asparagus, another great antioxidant and anti-inflammatory that also does have eye and brain health benefits, so another double whammy. Purple and blue, so that's going to be your resveratrol. You can find that in your blueberries and in your grapes, another antioxidant and anti-inflammatory agent. And that's been shown to prevent many kinds of cancer. A lot of people associate resveratrol with wine as well. So I know a bunch of people are drinking red wine tonight. You are getting your resveratrol in by drinking that, but obviously limiting the amount that we want to drink just to make sure that cancer prevention. And then also your allicin is going to be white. So you can find that in your garlic and your onions because you don't typically think about a lot of fruits and vegetables being white, but garlic and onions are two great sources. So that's another great antioxidant. And then coffee and tea, actually. So as long it doesn't fit in the rainbow, it's brown, but it does have great antioxidant and phytonutrient properties. And then vitamin A, C, E, and zinc are also known as antioxidants. They are vitamins and minerals, but they do provide you with other benefits as well. You can get those sources of vitamins and minerals from eating the rainbow. So just by eating all these good sources of fruits and vegetables, you're going to be getting your A, C, E, and zinc. So there are other lifestyle changes for prevention and also to prevent obesity. So exercising at least 150 minutes a week is the recommendation. If you've not been active in a while, please start slow and build up your tolerance to exercise and your intensity. And pick a mixture of activities. Keep it fresh. Maybe you'd want to do walking. Maybe you want to do some strength training. Don't feel like you need to go out and run a half marathon. That's not for everybody. It is for some, though, and I respect that because I can't do that. And then also you want to limit your alcohol intake. So for men, it's about 1 to 2 drinks per day is recommended, maximum 2. Women, it's about 1 drink per day, and that does also mean a normal serving size. So not the serving sizes that they served us tonight. I saw some of them were quite large, which is okay. But your normal serving size of a liquor is about 1 ounce. Wine is 5 ounces, not 10 ounces like these glasses or whatever they are. And then for beer, it's 12 ounces. So again, to reiterate, 1 to 2 drinks for men and 1 for women. And then obviously smoking, that has a lot of ill effects on our health. So if you are a current smoker, please stop. If you're able to, we have a lot of great programs at LVHN to help you stop smoking. If you're not a smoker, please don't start. So bottom line, we want to strive to maintain a healthy weight. That's going to be through our diet and exercise, eating a diet that's rich in plant-based foods. So again, your fruits, vegetables, whole grains, beans and legumes are all great sources of plant-based foods. Variety is key. So again, eating that rainbow, getting all different types of fruits and vegetables in our diet, not just eating, red ones or not just eating potatoes. Keep moving, staying active, going for walks as much as possible, going to the gym, but just don't sit there and be sedentary. And then work with a dietitian. If you're having trouble losing weight and you really want to lose weight, like I said, there's dietitians all across the network, not just within the Cancer Center. We're all over within LVHN. So if you're not a patient at the Oncology Center, we have dietitians that work with weight management, diabetes specifically. But if you are a patient at LVHN and you follow with one of the oncologists, we're a free service for any of the patients. So if you want a referral or anything, just talk to your doctor about it, and you can work one-on-one with us. We work with everybody from before, during, and after treatment. So doesn't mean you have to be in active treatment. And there's a lot of other resources out there, so I just listed a couple of them. There's a plethora of good ones, but MyPlate and EatRight.org are both great ones that we use as dietitians. And AICR is a great website to talk that gives you good tips and tricks on prevention and all other good recipes and stuff on there as well. And then there's my contact information, so my email and also my phone number. If anybody has any questions or concerns, you can ask me now, but you can also reach out to me via email or phone call if that works better for you. And that is all.
Thank you so much, Deanna. And You really inspired all of us to eat right and exercise. I'd like to really close the night with 4 special thanks. First of all, to Laura Beaupre, the entire PC Hope Foundation that's here. You've had our back, you've had the community's back, and have done a lot of foundational things, and we hope tonight can be the start of even greater involvement in helping fight this difficult cancer. And this second is I'd really like to acknowledge Laura Ferran and her family that's here and her friends. Laura is starting a foundation called Ferran's Fighters. It's also to support curing pancreatic cancer. Her husband Jerry was 47, fought advanced pancreatic cancer for 20 months. Really beat a lot of odds. Dr. Khalil and Dr. Eileen O'Reilly at MSK co-treated Jerry, and he was involved in clinical trials. Laura's and her family and friends have really made this a cause. So it's very, very similar to PC Hope because the grassroots efforts mean so much. Sometimes it's hard to see from here. Is Katie Beglini out there? Can I, Kate, is she outside? Okay, so Katie was the tireless organizer. She organizes our special events, and she pulls all of these off without a hitch and makes sure that everything's very comfortable. So great thanks. And Dr. Kevin Soros, we just want to thank you for the inspiration by your life's work. Your team, Dr. Vinod Balachandran was so kind, and I'm hoping, I know this will be the start of a very fruitful partnership, and we really appreciate you coming. He left clinic, came here, and has a long ride back. So really appreciate you being here and talking to us. Thank you so much, and thank you everyone for coming.